what's happening with our healthcare. It seems like every way they can get us, they're trying to get us. And, the misinformation, downright lies, it's confusing the people. Folks who have listened to them, unfortunately, during COVID, a lot of people died listening to the idiocy. Now with the vaccine, a lot of children are dying or will die. And we just need to get the straight story so that we are not passing on false information or passing on their lies. So, Mary, I think you need to introduce our guests and let us get started.
With pleasure. So I'll introduce Kathy Waligora, who is a colleague, a friend, and she is one of the leaders of the Protect Our Care Illinois Coalition, which just recently came together. Many organizations that are healthcare advocacy groups, healthcare providers, et cetera, came together to challenge what's going on in healthcare right now. Kathy is also policy director and liaison for external groups with EverThrive Illinois, which is an organization dedicated to improving the health of women and children. So Kathy's going to talk to us about vaccines, and then also will talk to us a little bit about what we're fighting over in the shutdown, particularly around the ACA. So go ahead, Kathy.
Thanks, Mary. And hello, I know a few folks on the call, but it's nice to meet all of you.
Froze.
Oh, I'm frozen. Can other people see me?
Yes, yes,
You're
yes.
okay now.
Yeah.
Okay.
Also wait, I just have to say that we'll let you talk, and then if people have questions, they can put them in the chat, or after you're done speaking, we'll take questions. Okay,
perfect. Yeah, so it's so nice to see you all, and thank you so much for having me. So yeah, like Mary said, my name's Kathy, she, her. I'm the Deputy Director of External Affairs at EverThrive Illinois, where I've been for 15 years almost, which is wild. And as part of my role at EverThrive, I am one of the founders of the Protect Our Care Illinois Coalition, which actually, Mary, we started back in 2016
Right.
and then let it lapse
That's right.
after we
remember that.
won the ACA repeal fight
Right.
in the first Trump administration. And then we got the band back together in the summer of 2024, just in case. And that was, of course, fortuitous, though this time we have not had the same success we enjoyed in 2016, as you all know, with the largest cuts in history to the Medicaid program. So my experience over the last 15 years, I've worked in advancing policies, both as a lobbyist in Springfield and DC, and as an advocate and policy expert here in Illinois. And I particularly enjoy that kind of intersection between policy as written and policy as lived, with the goal of achieving health equity, achieving reproductive justice. So I'm going to share just a couple of slides, and Mary and Deb have these. If they haven't already been shared with you all, you will get them because there are a couple of links. But it seemed like an easier way to, try and make sense of this conversation. So excuse me while I make my computer do what I want it to, which is never as easy as it should be. Okay, I opened that, but now I lost you all. There you guys are. And now we'll share. It said I need to send request. Someone's gonna have to okay me. Okay. There I am. All right. So yes, initially what we talked about with this conversation is getting into vaccines a little bit, talking about what's happening, why it feels so chaotic, and what has and has not changed, where things will go. This is a big part of my job and what I talk about, and I'm really excited to talk about that. As Mary mentioned, I also, as leader of Protect Our Care, am involved in, it was a big part of our Medicaid defensive work, will continue to be a big part of that for the next however long. And I'm doing some work around advanced premium tax credits, which is, of course, at the center of the current government shutdown. So I'm happy to kind of talk about all of those things, but let's go through vaccines first. And I'm just going to give you a warning. We might be fine, but I have a 3-year-old who has a UTI and got her flu shot today, so she might pop in. We'll see how long she's willing to sit with her less favorite parent of my husband. Um, so very briefly about EverThrive. This slide is basically the core of why we exist. We exist because of the belief that having and raising a healthy family is a human right, but not all families have the same opportunities and access to resources to thrive. We know this is especially true for folks who come from communities that are marginalized, Black and Brown communities, immigrant communities, LGBTQ folks, people who live in certain parts of the state, right? Rural communities versus urban communities have their own challenges. And so we really look at those disparities and figure out how to close those gaps in order to advance reproductive justice and health equity. You'll get these slides. So if you want to read more about how we think about reproductive justice and our mission, vision, and values, it's all there. But I could easily fill our hour talking about that. I do want to give credit to Mary and Ellen, who are founding board members for our organization. So I already mentioned this. This is kind of where we're going. Very high level slides. Please put your questions in the chat. If there's something that an acronym I've used or jargon or something, feel free to just come off mute and ask so that we don't get lost in the conversation. I apologize that this one's a little fuzzy. I pulled it off of a Substack, but this is the anchor. So in order to talk about what's happening with immunizations right now, we have to like roll it back a little bit and talk about how things are supposed to work. And probably, I don't need to say this in this group, but you never know anymore. So I actually want to roll it all the way back to the very basic premise that vaccines save lives and that vaccines are safe. By time vaccines get to market, we have a very high confidence in their safety. Those two beliefs are, of course, people who challenge those beliefs are the ones who are making a lot of decisions about vaccines right now, and that's why it feels so chaotic and confusing. So this is the regular process by which a vaccine is sort of approved and comes to market. And this really focuses on the final steps in that approval process where the federal government comes in. And I'll explain why that's important as we go. So step one is this shot over here, right? And this in and of itself is a very long process most of the time, COVID being the one exception in some ways. But clinical trials, real world data, whatever that looks like, the people who are trying to make vaccines are doing a ton of testing and data collection to determine that they are effective, to understand the mechanism that makes them effective and at what point they're most effective, and make sure that they're safe, and understand side effects, right? All medications, I think, can have some side effects, and certainly immunizations are not alone from that, but making sure that those side effects are not disruptive to folks' well-being, that they are an appropriate trade-off for the immense protection that vaccines provide. So once that very long process is over, represented here as just one dot, then we start to go to expert panels to get federal government approval and recommendation of vaccines. I don't even have, I was going to look up the name of the acronym because BRBPAC, I'm never going to remember what it stands for. But this is a group of experts, an external group of experts that advise the FDA on whether or not vaccines should be approved by the FDA. So this independent panel is kind of looking at all of that clinical trial data, that real world data. They're really understanding and asking a lot of questions and determining whether or not this is something that the FDA should consider. That committee is tasked with telling the FDA, yes, we believe this is safe. Yes, we believe this is effective in the ways that's described or otherwise. And we think that it would be appropriate to recommend this. The FDA will then license and approve a vaccine. So they say, yes, this vaccine can be given to people, and yes, this vaccine can be sold. And typically, until that happens, vaccines are not being manufactured in any significant way. Told you. Hi, baby. Come here. This is Eleanor. So until FDA licensing or approval happens, typically vaccines are not being produced. I mentioned that because with quickly mutating diseases like flu or COVID, this all gets kind of muddled together, which ended up being really important this year. After FDA licenses and approves a vaccine, then ACIP, the Advisory Committee on Immunization Practices, oh, she's going to look at her face now. ACIP will review, again, it's an external body of experts, typically 17 members, who advise the CDC on who should get the vaccine and when. So FDA will license it for certain groups, but ACIP will say, here's who should definitely have it and when they should get it. That group meets 4 times a year, every year. They look at all kinds of information. They don't always vote, but they do vote on any vaccine that needs to be actually administered to folks. ACIP is important because they advise the CDC director. Okay, honey, can you go with Dada? I bet Daddy has M&Ms.
M&Ms?
ACIP will advise the CDC director, who will then formally say, the CDC says this is who should get these vaccines. That creates the schedule that we are used to seeing. There's a childhood schedule, an adult schedule. And the CDC, ACIP, FDA, all of that comes together so that then you get that printout that tells you when to get a dose of a vaccine or not. For flu and COVID, this happens every year, right? A new vaccine is created every year. It goes through this process. Typically, the VRB PAC FDA process begins in February. Right? So flu peaks in March, April. Most folks get vaccinated in October, but the process of actually reviewing the flu vaccine every year and now COVID begins in February. This year, it didn't start until June, which is why we've had delays in getting that. And that is very much intended to prevent people from getting the vaccine. The last step in the process is public access. And that doesn't just mean it goes to Walgreens and people can get it. It means that your insurance will pay for it. Okay, Ellie, you need to go with Dad. Sorry, 1 second. Yeah, time to go with Dad. I'm not done yet. I'll see you when Paw Patrol is done. So public access doesn't just mean that it's gone to Walgreens. It means that your insurance is going to pay for it. And that's really important because, as you can see, those steps are necessary, especially that ACIP recommendation. So to get a little bit more into that, and then we can talk about what has actually happened. There are basically 4 major payers for vaccines in our country. Vaccines for Children is the single largest payer for all vaccines. Vaccines for Children can only, it's a program created under the Clinton administration that basically buys vaccines in bulk from the manufacturers and distributes them at an immense discount to providers who see kids that are uninsured, underinsured, or fit into a couple of vulnerable groups. VFC pays for like 74 million doses of vaccine every year. Tons of vaccines are bought by the Vaccines for Children program. This is how all kids enrolled in Medicare or Medicaid get their vaccines, but even some kids who are not get their vaccines this way. VFC can only purchase and distribute vaccines if they are recommended by ACIP. If they are not, then those funds cannot be used to purchase those vaccines. And that means that vaccines that are not approved by ACIP and can't be distributed by VFC, there's no incentive for the manufacturers to even make them in a lot of cases. So that becomes really important as we think about ACIP and what's happening right now. The Affordable Care Act includes a very famous provision, you likely know about it by now, that all insurance plans must cover preventive services without cost sharing, including all ACIP recommended vaccines. So your insurance company may choose to cover other vaccines, but they must cover those vaccines that are recommended by ACIP. So again, that body is really important for anybody who has private health insurance. And finally, Medicare. Medicare Part B covers a very small set of vaccines. It's flu, pneumonia, pneumococcal, I think, and then other covers like tetanus or rabies if you've been exposed to that through an injury or a bite or something. And Medicare Part D must cover all ACIP recommended vaccines. So basically, ACIP decides who should get a vaccine, and then all of the insurance is required to follow suit. And that matters because ACIP is at the center of focus for Bobby Kennedy and all of his anti-vax friends. And that's where we've seen a lot of the chaos coming from. I put the federal strategy right now on vaccines into 4 categories. They are removing experts and circumventing the usual order. This process is expert-based. It's external to the government, right? We have people with lots of different interests, none of them from the pharmaceutical companies, reviewing this data and making decisions. And we have them doing it in a very predictable and transparent way. They are circumventing that predictability and that transparency, and they're removing those experts. They're creating messaging chaos in the way that they talk about vaccines publicly. Whether they change their guidance on the measles vaccine doesn't matter if your head of HHS is out there saying that the measles vaccine is causing autism and autism is a bad thing we should always avoid. They're issuing contradictory agency guidance so that no one who has to make decisions based on the law knows what to do. The law is clear. This body should say this, and then that body should say that, and then that should mean you do this thing. But if the FDA is saying one thing and the CDC is saying another, and ACIP falls somewhere in the middle, it's actually not clear statutorily what should be done. And then finally, non-transparent decision making, which we'll talk about. Again, this is a very transparent and predictable process. They claim that it has never been transparent and it has never been predictable, and now they're actually undoing all of that work and making it the system they claim it always was. So what have they actually done? Now that we've gone through all of that background. There have been a lot of actions on vaccines, and when I was putting together this list, was trying to think about how to reflect this. And I decided to focus on the decisions they've made that have directly impacted the production or availability of vaccines or will directly impact that, right? So I'm taking rhetoric and reports and all kinds of other stuff out of it and saying what has actually impacted the ability for someone who wants a vaccine to get it. And this is where I definitely have to look at my notes. So way back in April, we had CDC guidance change on the COVID vaccine for healthy children and pregnant women. The CDC, who issues that final schedule based on everybody else's input, acted on their own to say, actually, healthy kids and pregnant people probably shouldn't get the COVID vaccine. And they moved it from a recommended part of the schedule to something called shared clinical decision making, which basically means you should talk to your doctor and you guys should decide together if this is right for you. Of course, that's what all of us are doing in practice, right? But when the schedule says you should get this every year or you should get this at 4 and 6 or whatever, that's more prescriptive or forceful than shared clinical decision making. This happened without input from the FDA, without input from ACIP, and in fact happened after RFK tweeted that he thought it should happen. And then the CDC issued that change. So this was an important example. It directly impacted people's understandings of whether they should get this vaccine. We haven't heard of any pregnant people or kids who weren't able to get it if they wanted, but I don't think that's because it doesn't exist. It takes a lot for a story to trickle up to me, right? And it reflected this change from the expert, predictable, transparent process. A month after that, in May, all 17 members of the Advisory Council on Immunization Practices were fired, and they were replaced in part with anti-vaccine advocates, and in part they were not replaced. Seats were left open. There are 1 or 2 folks on ACIP now who are not known anti-vaxxers or industry plants. There are healthcare industry investors also on this board. So I guess I can't say it was 100% replaced with anti-vaccine advocates, but largely that's who is seated on that board. That board was fired and replaced in May, and in June, where they would typically vote on COVID vaccine, they elected not to. The FDA still had not done what they needed to do, we believe, because of the direction of the director of HHS. And so then in June, ACIP said, well, we can't vote on COVID. And they didn't. Then finally, they also at that meeting in June, they like reviewed data about the kids' immunization schedule, and they kind of started to raise questions that we use to think about what's coming, that hinted that larger changes are coming. But so June they didn't meet. July or August, the FDA finally approved the fall vaccines. Flu was approved as normal, but COVID was approved only for certain groups, right? So FDA approved COVID vaccination for adults with certain health conditions and for kids with certain health conditions and for folks over, I think it's 75 was the only group that they universally approved it for. And then they listed out this long list of either pre-existing conditions or other sort of lifestyle things that might mean that you should get the COVID vaccine. In the past, they had approved it for everybody 6 months and up or for all adults or something, right? This decision, coupled with the skipped vote in June, is the reason that in September, so many people had trouble getting the COVID vaccine. Pharmacists in most states can only administer vaccines for on-label use. So they can only administer vaccines according to FDA approval. And because ACIP had not chimed in any way, there was no other information. And that's why you saw folks, not in Illinois, thankfully, but in places like New York, having to go to their doctor or get a prescription to get it at the pharmacy or otherwise facing these barriers because of these couple of cascading decisions. In September, so just 3 weeks ago, ACIP met again, and they took some pretty big votes here, though again, signal bigger changes coming down the line. They voted on COVID, and their recommendation for COVID fell kind of a little bit more expansive than the FDA approval, but not a universal vaccination. In the past, ACIP has said everybody 6 months and older should be vaccinated against COVID annually. This year, they put out a recommendation that you should talk to your doctor. They did this shared clinical decision making. If you are not a person with pre-existing conditions or in one of these categories, the FDA specifically said you should talk to your doctor. In the meeting, they acknowledged that this is because there may be folks who want this vaccine who can't get it because of the off-label use. They tried to require a doctor's prescription, and that vote failed. It was a tie vote. That, of course, would have erected a huge barrier for a lot of folks in getting the COVID vaccine. And again, it reflects a shift with ACIP and with the CDC in general to restrict access back to vaccines as opposed to widen access to vaccines. They also voted to no longer recommend the MMRV vaccine. MMRV is measles, mumps, rubella, varicella. Varicella is chickenpox. For a long time, we did MMR and then varicella separately. They got combined, a long time ago. Most people do not receive that combined vaccine. Only about 4% of kids are receiving that combined vaccine. And they opted no longer to recommend it because of a slight increase in the incidence of febrile seizures following vaccination. Febrile seizures, while scary for parents, are a typical vaccine side effect, or not typical, but are a normal vaccine side effect experienced by a very small number of people. And they, rather than kind of letting that information be out there and allowing folks to make a choice, they opted to remove this from the market, effectively remove this from the market by not recommending it. This means VFC will not pay for it. Other insurance companies may not pay for it. They also had some votes scheduled on hepatitis B, which is an infant vaccine given to newborns that was based on junk science, and they ended up not taking that vote. But again, they've signaled their intention down the line to look at the entire childhood vaccine schedule. So we've got kind of these actions that unless you're paying really close attention to, you might just see a headline here or there. I know after the September ACIP meeting, I saw a headline that said, you know, something like RFK's panel votes to remove measles vaccine. There's a lot of information to keep track of. If you're not following all of the details, it might feel bigger and more chaotic than it is. That's of course by design. And it's signaling the direction that we're moving in. We expect that ACIP over the next, I can't predict how long, but over time, whether that's months or years, will try and move the entire vaccine schedule to clinical decision making, and potentially remove some vaccines from that process altogether, like they did with MMRV. That means it will be more difficult for folks to get their kids vaccinated. It will be more difficult for adults to get vaccinated, as we saw with COVID. But it's not all dark. We are seeing some positive movement from the public health sector, actually from the healthcare industry and from the states. I'm going to talk very briefly here, and then I'll go into a little bit of detail about what Illinois is actually doing. So in April, before all of the things I just went over, the University of Michigan launched their Vaccine Integrity Project. We point to the CDC all the time as the gold standard for understanding what vaccines should be received when and by who. And it was clear with the appointment of RFK that that was at risk. And so the University of Michigan began pulling together their own body of expert advisors, just like ACIP, to meet on a similar schedule and issue their own joint recommendations, look for more research, review the data. So basically somewhere we can look to as the set of actual unbiased experts who are working to advance public health. That group has been issuing some recommendations. They've been putting together recommendations for states on how to respond. We've also seen provider associations issuing guidance. So every year, the American Academy of Pediatrics puts out their own vaccine schedule. You just don't hear a lot about it because it's the same vaccine schedule as ACIP every year until this year. American College of Obstetrics and Gynecology, they put out their own guidance on vaccines. They always have, but it's always been in agreement with the CDC. Those provider associations still issued their own guidance, and they stayed true to what their experts and clinicians saw in the data and the research. And so these provider associations are issuing guidance to their physicians and to their patients that differs from ACIP and the CDC. Like I mentioned, my daughter just got her flu shot like an hour and a half ago. And I talked to her doctor, and the doctor said, we are following Wisconsin AAP recommendations at this point. So there is information for clinicians to work with. AHIP is the Association of Health Insurance, American Health Insurance Plans, Association of Health Insurance Plans. It's the association of private insurance providers. It includes most of the largest providers on the market, Blue Cross Blue Shield, Anthem, a whole bunch of others. United is not part of this group, which is important because they're a big insurer in Illinois. But that association, prior to this September ACIP meeting, issued a statement saying whatever ACIP does or doesn't do, they will continue to cover all vaccines that were recommended by ACIP earlier this year without cost sharing. So for at least one more year, most people should see their private insurance covering, most importantly, the COVID vaccine, regardless of the ACIP recommendations. Prior to the ACA, a lot of insurance plans didn't cover the vaccines that people needed, right? I remember my mom paying out of pocket so I could get the Gardasil vaccine, even though that vaccine was approved by ACIP at that point, because it was new, and so my insurance didn't cover it. We will see over time, we could see in that sort of return to that sort of market. Your insurance may or may not cover all of the vaccines that your doctor says you should get, if ACIP is not recommending them. And then finally, states have taken action. A lot of different states have done different things. So I want to talk about the two big actions out of Illinois. Right before the ACIP meeting in September, Governor Pritzker issued an executive order. I've listed out all the things that it does here, but it basically did three big things. One, it authorized or encouraged the state IDPH to use the guidance of our own state advisory committee on immunizations, which has existed for a long time, to create a stockpile of vaccines. So again, VFC is not going to be buying those vaccines, but under this executive order, IDPH and other players in the state are figuring out how to buy those vaccines. That should help keep things on the market, even if AFC or ACIP doesn't recommend them and VFC can't provide them. It will also ensure, of course, that kids can get them without cost barriers. It also encouraged the director of IDPH, who is a medical doctor, to issue standing orders on vaccines when necessary. He did, just a week later, issued a standing order on COVID-19 to say all people over 6 months of age should be able to get this vaccine without barrier. What that does is ensure that pharmacists can continue to provide that. Most people these days are getting vaccinated at a pharmacy and not at their doctor's office. And so we need to have that standing order for the pharmacists to work from. And then the last thing it did is really just kind of put out there a reminder that outreach and education is really important, that connecting to communities is really important, and guide the agencies to continue to support and fund that work. Right after that happened, the Immunization Advisory Committee met. They reviewed the fall respiratory vaccination recommendations or vaccine data, and they ended up issuing their own recommendations. They want universal, they're recommending universal COVID vaccination for everybody 6 months and older, universal flu vaccination for everybody 6 months and older, and RSV vaccination for certain pregnant people, children, and adults. The difference between Illinois and ACIP here is that COVID vaccination, and that recommendation is what then triggered the director of IDPH to issue that standing order. I expect as time goes on and ACIP reduces access to more and more vaccines, we will see the state fill in this same process. The state advisory committee will meet, the director of IDPH will issue standing orders, and as long as it's just ACIP doing this, we should be able to circumvent at least the negative access impact. Overcoming the rhetoric will be difficult, but we should be able to ensure access. If FDA removes approval for a vaccine, that is going to be, as far as I'm aware, impossible for the state to overcome. Interesting solutions come up over time, so who knows? I don't want to say anything is ever impossible, but as long as ACIP is the one that's doing weird stuff, we can overcome that. If FDA starts pulling approval, that's a lot more difficult for us. If we have a stockpile of approved vaccines, that buys us time, which is, again, part of why we're seeing that stockpile being built. One thing I know a lot of folks have heard about that didn't happen in Illinois that I want to talk about is a multi-state compact. So I think perhaps most famously, the states in the Pacific Northwest, Washington, Oregon, California, have come together in a multi-state compact. So they're issuing recommendations on vaccines together, and they are building their stockpile together. We didn't do that in Illinois, and I can't say exactly why. No one has told me why we didn't do that, but I have two guesses. A third guess that is really, really guessing, but you seem like the group that'll want to hear it. So my two very clear reasons that we're not doing it. One, the states that border Illinois are not as politically aligned as California, Washington, and Oregon, right? So it's tricky to tie yourself to Missouri, Kentucky, maybe less so Wisconsin, but not entirely Iowa, right? You just don't know what those states are going to do. So you don't want to be in a compact with them with any risk. It also would not that diseases don't know borders, but Illinois has a lot of purchasing power on its own. And so Illinois would gain the least from sharing that vaccine stockpile, right? California is basically helping Washington and Oregon by participating in that stockpile. So again, since the politics are different, I'm guessing a lot of other governors who border Illinois were not asking for this, and that's why we didn't enter into that. My third very speculative reason is Governor Pritzker wanted a lot of credit because of his larger political ambitions. I don't think he wanted to share the spotlight. So these are kind of the actions that have been taken in Illinois. In terms of what's next, I don't have anything fancy on the slide, so I'm going to stop sharing. But I think, as I've said, what we can expect going forward is at each ACIP meeting, there will be a new vote on a vaccine that will result in reduced access. And that is bad, objectively bad. And also, we have this process in place in the state now that should allow us, at least for some time, at least for the next year, to maintain the level of access that we have, generally speaking. People will fall through the cracks. There will be plans, for example, United, who has not committed to covering vaccines, that may stop covering vaccines. We will wait to see that and try to document those harms so that we can push back and correct them. But I think for the next year, things will be relatively stable in terms of access, but the rhetorical context, the education, the headlines, the coverage will be enough to result in people not being vaccinated, right? We're seeing it already. It will be, vaccine rates will continue to fall in every category for every vaccine, as long as our public health leaders are not committed to advancing vaccines. So we'll see continued growth in the measles outbreak, in other public health outbreaks, and we will see fewer and fewer folks vaccinated.
Kathy, this may be, I'm sorry, just a good time. Someone asked in the chat, Terry actually, she said, why is United Healthcare not part of the group? So many of us are insured with,
Yeah.
United.
So United has never been a part of the Association for Health Insurance Plans. I don't know why that is exactly. I know as a health insurance lobbyist who does not work for insurance, when I think of the good actors and the bad actors in Illinois, United has always been less willing to do the right thing. I don't know exactly why that is, but I know they're not a part of this association. United, as far as I'm aware, has not said anything either way in terms of what they plan to cover. So they may still cover vaccines going forward. But the fact that they weren't a part of that group committing to cover vaccines is obviously troubling because they are the second largest health insurance provider in the state of Illinois. And what they cover, right, if you have like a Medicare plan and you have United, is different from their commercial product. They are going to be bound by the ACIP requirement for Medicare, which at the moment has not changed for older adults. So the coverage should still look the same. Thank you for that question. I think one of the things, just to wrap up the conversation on immunization, one of the things I hear from folks a lot right now is like, what can I do? And this is a tricky one because it's not laws that are changing. I think that there are a couple of things. It never hurts to call your member of Congress. They need to be hearing that people are deeply concerned with the actions of the Director of Health and Human Services because it's not impossible, right? There is a world where he is unseated and we can start to undo this work. I don't think that's highly likely, but it does not hurt. I think the most important thing you can do right now is get vaccinated and talk to your loved ones about getting vaccinated. If you're thinking about whether or not to get your COVID shot, like get it this year because it might not be there next year. And then as opportunities for more action arise, I think you'll be hearing from groups like ours. But right now, the most important thing you can do is get vaccinated and talk to other people and point them to good sources of information. EverThrive's website, we have a ton of campaigns around vaccination. We work with the Chicago Department of Public Health and the Illinois Department of Public Health. Going to the association or the American Academy of Pediatrics or ACOG, whatever provider group is most appropriate, and seeing what they're saying and sharing that information with folks in your life is really the most important thing. I know that's not always as satisfying, but we really are the ones looking out for each other. And I see there's another question. Is there going to be a national source of data for states to use, or do the states or groups have to make their own data, have their own data in making decisions? So a lot of the data from the vaccine trials and everything, if not all of it, is made public as part of the FDA approval process and can be provided by the pharmaceutical companies directly. So right now, I think the state is getting their data from FDA to decide what to do, but they could theoretically get it directly from the companies that manufacture vaccines and then review that independently to decide if it's correct. This is also where the Vaccine Integrity Project comes into play, right? It could be a lot for each state to be reaching out individually to each vaccine manufacturer. So as time goes on, I think the Vaccine Integrity Project will be the ones kind of receiving that information directly. We should always be skeptical of people who want to profit off of our concerns and our health. And that said, vaccine manufacturers have been really important players in this. They don't really make a lot of money off of the vaccines, right? They kind of do this as part of the public health. They receive other support. And the drug manufacturers do have an incentive if they want to bring something to market to provide that data to whatever body is going to help them do that. So, we have worked in this space for a long time. We've certainly been on the receiving end of vaccine manufacturers lobbying us to support their vaccine specifically, and we've never done it, but they continue to work with us. And that's important for getting that information that might be more difficult to get in the future. Go ahead, Terry.
I heard today, in between all the Chicago news, that they were separating the MMR part more, or they were talking about instead of just taking the V off. Did you hear discussion on that? And where do you think that's going?
So we've always had two vaccines. So there's the MMR vaccine and then there's MMRV. And
Right.
so most
about-
96,
Yeah.
what was that?
What I heard today was about the MMR.
Yeah, so MMR has always existed and 96, well, not always, but for a long time. And 96% of kids in the last year who got vaccinated against measles received MMR. So that vaccine has always been there. There has long been the vaccine that ACIP no longer recommends is MMRV, which was MMR plus the varicella vaccine. Varicella is available independently, and most kids are getting that varicella vaccine separate from their MMR. That's why now kids don't get chickenpox, right? Which is very strange because even for me, we still just expected to get chickenpox. Now no one expects it. So MMR is still there. There has been an anti-vax push for a long time to say, well, just separate out M from R, right? Measles from mumps from rubella. Couldn't this be 3 separate vaccines? And your local epidemiologist, she's big on Substack. She is an actual epidemiologist, an expert in public health, has a long post on this explaining that the way the vaccine is produced, you cannot separate M from R. And more importantly, it's long been approved, tested, and reviewed, and we know that it is safe and effective when given as a single dose. It's also interesting, right? Because RFK has been a proponent of this message, and other folks, I think, are starting to hear it in other places and pick it up, even if they don't have anti-vax sentiment, right? But there's this sense that kids are getting too many vaccines, they're getting vaccinated against too much. If that's really what you thought, why would you separate one vaccine into 3 and then add 2 additional vaccines, right? So there's a bit of a disingenuous idea there that's used to kind of get into people's heads and get them to question the schedule that's in front of them. We're not going to see MMR get separated into 3 vaccines because from what I understand, it's not possible, but it's also not necessary. It's really a talking point that's being used to try and bring more folks over.
Yeah, I just heard it today, so it scared
Yeah.
me.
I had just started to hear I'd heard about it a long time ago because I actually have an anti-vax sister. So I've heard all of the talking points, but I heard it from someone other than her just a few weeks ago. So I do think it's picking up steam, and it's one of those things that to any person sounds reasonable. Well, if somebody wants to vaccinate their kids against measles, but who cares about rubella, right? People should care about rubella. Shouldn't they be able to choose just the one vaccine? But that's just really not how it works to manufacture and distribute these vaccines. And again, it's not necessary. I want to take a few more minutes for questions on immunizations before I pivot to shutdown, which I have just a couple of minutes on because the news is going to tell you almost everything I could tell you, and make sure we have time. Go ahead, Jackie.
Yeah, during COVID, we had the CDC that gave us information on deaths as they were happening in different states. With the disruption in the CDC and the craziness going on there, will we know what happens with children who do not have vaccine immunization that end up unfortunately dying?
It will be much more difficult to know. So, basically, if a case of, let's take measles for example, but it could be other things, right? But if a case of measles happens in a state that wants to be transparent, we will get that information. If a measles death happens in a state that wants to be transparent, we will get that information. If a measles death or a measles case happens in a state that doesn't want to be transparent, that doesn't mean we won't know, right? You may see reporting from other sources, but it's going to be a lot more difficult. The Vaccine Integrity Project, that's part of what they're thinking about, right? Is how can we at the University of Minnesota be doing this sort of national surveillance in addition to the review of vaccine data, to provide that public health data. They are just through their planning phase, right? They didn't exist before April. So we'll kind of see what that ends up looking like as it becomes more necessary. But it's definitely a big concern. We will not have the same sort of public health data and surveillance that we would have, because there's freedom to not do that. It's not going to be coming from the feds. It's not trustworthy. There are states that can choose not to do it. And then, that's to say nothing of all of the funding that they've cut for these programs, even in the places where there is a commitment to this work. Go ahead, Judith.
Did you have a question? You're on mute.
I think she's trying to find the window. There we go.
Carrie, can you unmute her? Yeah.
I'm just trying. So this is an economics question. Because we know it's more expensive for healthcare if people go to the emergency room, I'm wondering for insurance companies, is it cheaper to give vaccines than to treat the increased number of people that get the
Yes.
disease? And so
Yes.
why aren't they more pro, or are they pro? And isn't that an argument that's being used, even an economic, if it's not a health argument?
Yes, that is precisely why we saw the Association of Health Plans come out and say, well, of course, we're still going to cover your vaccines. They don't want to pay for your COVID admission, right? If you are an older adult, if you're a middle-aged person and you haven't gotten your vaccine for some reason, there's a chance that you will be hospitalized. They don't want to pay for that. Same thing with your flu, your measles, whatever it might be. So that's why we saw that group of insurers come out and say, we're going to cover this no matter what. That's what I would like United to also say. And I expect that at least for the next year, they're probably going to, because it's good business and it's kind of like good PR, right? People like getting their preventive care for free. People wish they could get more care for free. And so it's a way that the insurance companies can make an economic argument back to the consumer to say, well, we're covering these services for free. Look at all this health care you get. And you pay nothing except for your monthly premium, right? So that is exactly the argument that we are always making, and that is why vaccines for children exists. They found in the 90s, when there was a huge measles outbreak, tens of thousands of cases, that most of the kids who were getting sick with measles were unvaccinated and had seen a doctor in the last year. And they weren't getting vaccinated because it was too expensive, because their insurance didn't cover it, because they were uninsured, whatever. And so that's how VFC came to be. That's exactly what resulted in the ACA requiring coverage of preventive care. I think pre-ACA especially, insurance companies didn't have to cover a lot of stuff. And so vaccines didn't stand out. Post-ACA, where insurance companies do still have to cover all 10 essential health benefits, the vaccine change would stand out a lot more. So I'm not too worried about private insurance, at least in the immediate year to 3 years or so. If this really gets crazy, right, as demand decreases and it's less of a marketing tool for them, we might see more bad actors. And once a few plans start to do it, it becomes easier for other plans to do it. What I worry the most about is VFC. We don't have the same economic argument there because VFC is directly tied to the ACIP recommendation in statute. So you'd have to change the law with Congress in order to change how VFC works. If VFC can't pay for a vaccine, there is a very real chance that manufacturers just won't make it because it won't make sense for them economically if their largest purchaser can't purchase. So yes, your argument makes perfect sense for the insurance companies, but if VFC, which is not driven by the same incentive, can't buy it, it kind of doesn't matter. For kids, at least, those vaccines could end up, you kind of create like a death spiral. That spiral will take years. We have plenty of opportunity to circumvent that, to be perfectly clear, but that's the future that we worry about. Any other immunization questions? I can turn very quickly to shutdown. So I don't have any slides on this either because slides that I made on Friday were very likely to be out of date by today. But Protect Our Care Illinois, our position, which is also EverThrive's position, so I can represent both in this conversation, is that we should not see any support for a appropriations package or continuing resolution that does not include the extension of the enhanced advanced premium tax credits, which I'll talk about in a second, and a reversal of some of the worst changes in the One Big Beautiful Bill HR 1 reconciliation. Here she comes again. And the reason for that is that we don't have any other leverage points in Congress to assert that American healthcare should be at the very least not so outrageously unaffordable. And so this is our last chance until the midterms to maybe actually do something here. The changes in HR 1 are going to be devastating for rural healthcare providers, for other healthcare providers, for the Medicaid program. And so we should be doing everything we can to undo those. Additionally, the Affordable Care Act created advanced premium tax credits to help individuals and families with incomes below 400% of the federal poverty level pay for their premiums. In COVID, we extended those and created the enhanced advanced premium tax credits, and they have helped get so many people into health insurance by making it more affordable. Those tax credits are not permanent, so they're set to expire in December. And if they expire, we're going to see significant increases in premiums for folks right around 400% of the federal poverty level, which sounds like a lot, but is like $95,000 for a family of 4 or something. It's not that much. In Illinois, a couple who is 60 years old and at 401% of the federal poverty level will see an increase of $25,000 per year in their premiums if these tax credits expire. That's obviously not realistic for anybody to stomach. The result would then be fewer people get insured. That drives up premiums for everybody else who is insured. Insurance companies, when people start opting out, they assume the people who opt in are sick. And so they set premiums higher. So we're seeing premium increases of about 35% in Illinois this year on the assumption that these tax credits will expire. If Congress doesn't act by November 1st, we're kind of locked in to this scenario. If they act by November 1st, we actually have a whole set of insurance rate filings that we can go to that mean our premiums would not increase by that significant amount. But if they don't do it by November 1st, when we're all enrolling in our health insurance for next year, we're locked in for at least 1 year into these terrible rates. It'll be more expensive for everyone, and people will get less assistance to buy their health insurance plans. That causes a death spiral, right? Where there's more uncompensated care at a time when we've just cut Medicaid to the tune of $1 billion. So we are in a crisis when it comes to access to healthcare in America, and we are at one of the last points we have to assert ourselves and say this must be addressed. We cannot wait until potentially a new Congress is seated to try and take care of this. And so that's why Protect Our Care joined many other groups across the country, most importantly, Indivisible, in saying this is a red line for us. We must see some healthcare provisions included in any funding bill in order to support it. As of right now, all of the Democrats in the Senate are holding that line. We've seen support from Senator Schumer, as you all have seen in the news. We're hearing rumblings. There's a lot of back and forth, and it all centers on those enhanced advanced premium tax credits. I dropped a link in the chat. It's for the resources page on the Protect Our Care website. The very top resource is our short, like 3-page message guide, but it's also in effect a fact sheet about the advanced premium tax credits. I wrote it, so I think it's really good. And that explains a whole lot more about that issue and why we think it's important enough to be okay with a government shutdown, which is not something we should ever be okay with. Government shutdowns are bad. I saw it described by a group as being like the flu. It's going to happen every year. We know about when it's going to happen, and it will hurt people to have a government shutdown. But there's no alternative available to us right now, so we should be using every tool that we have. I don't know any better than anybody else when this is going to end. I do work with our members of Congress every day, and I'm not getting any insider information that makes me think this is ending anytime soon or that things are going very well. So we'll see where it goes, but I wanted to make sure to share with you all why we as healthcare advocates have drawn this line in the sand. We have 2 minutes left before that crazy child is going to come in here again. So I'm happy to answer any other questions. Also, I'll put my email in the chat. It's also in the slides that Mary and Deb will share with you all. And you can feel free to reach out to me anytime if you have questions or other groups that you think should get this information or other information. I can blab at you for hours about Medicaid too. Any last minute questions or final questions?
No, well, actually, Medicaid, you really, excuse me, you really didn't talk a lot about the impact on Illinois from the Medicaid cuts. I mean, what are we looking at in terms of our neighbors, being without health insurance if nothing changes?
Yeah, we're looking at least 500,000 Illinoisans who will lose health insurance over the next 10 years, most before 2030. That said, we don't expect any significant losses in coverage until next year when some immigrants lose access to Medicaid. And then again, there'll be a big wave in 2029 if and when we're forced to implement work requirements. We will also see changes, and this is its own whole seminar, right? We will see changes in these really wonky things, the provider taxes and state-directed payments. Those changes that are being forced by the federal government to how we finance our Medicaid program in the state of Illinois and how we direct our funds are going to be what closes rural health centers, safety net providers. Right now, we have a state-directed payment that will have to be cut under the ACA that provides additional funding to safety net hospitals with labor and delivery units. When that goes away, those safety net hospitals will close their labor and delivery units and people will have fewer places to deliver children, and as we already have significant healthcare deserts. So it's bad. That's where we'll start to see cuts to Medicaid eligibility as those are implemented over the next 5 years. We'll start to see cuts to Medicaid eligibility and services outside of the group that the Republicans in Congress love to talk about, which are ACA adults. That's where we'll start to see services cut for kids and pregnant people and folks with disabilities. We don't know what that looks like yet, but the next 5 years, the state will be forced to do a lot of cutting because the federal government is really tying our hands, is the very short answer to your question. Protect Our Care, we actually have a webinar on that same resources link that I shared. It's the third link. It says slide deck. Oh, that's PIF. The fourth link, July 25th, policy briefing. We had tech problems, so there's a part 1 and a part 2 because we all got kicked off the webinar. But we go over in detail what we know about how the One Big Beautiful Bill is going to impact healthcare. So I would recommend checking that out. It's 90 minutes, and even that is too short to really get into it. But continue to follow Protect Our Care. Our website is there. We're on social media, though we're a little bit inactive at the moment. We'll be back. And we share a lot of information through those channels to help folks know what's really happening.
Kathy, I think we're signed up, Chicago Women, as part of Protect Our Care, but if we're not, please send me the forms and I'll sign
Yes.
us up and we'll,
Yeah, I saw your email today and I didn't have a
Yes.
second to respond, but
Yeah,
I'll
very
double
good.
check and I'll make sure you guys are listed.
and we hope your daughter gets better fast.
Thank you. The chocolate around her face suggests she's feeling better already. So thank you. Thank you for tolerating that. I thought it's been a while since I've tried to do an evening thing from home and not at the library. And now I know I got to go to the library. Yeah.
It was fine. It was really
No,
fun.
we like children.
Yes.
Yes.
They're
Okay,
fine with us.
good.
Even
And-
with smiles.
I
Yeah.
appreciate you guys so much. I need to go do bedtime now, but like I said, feel free to be in touch. Connect with EverThrive. I didn't share the link, but we have a way to
We
sign up
can.
for our Policy Action Network in those slides, so you can receive more information from us as all of this continues.
Thank you so much, Kathy, for coming on and